All right, here's the proper presentation for the 12 Lead ECG review. So here's some quotes I want to start the class off with. Captain Lash is a firefighter for Columbus Fire Department. He has retired. He's spent 40 years in the service, and he's still teaching to this day. So I got some quotes from him on here. You aren't entitled to anything but hard work. A bad attitude's like a flat tire. If you don't change it, you're not going anywhere. And then myself, my quote is your responsibility to be accountable to your actions. Don't ever forget that. There's nobody else's. So I'm going to start from here, and this diagram here is going to be directly relating to the first part 1 video where I was talking about locations of 12 leads and where things were. So we're looking at V1, V2, V3, and V4 being the left anterior descending artery, which would be right here, as you can see. And you got the lateral side, as you can see over here. So you think of the lead 1, AVL, as well as V5 and V6. So your high lateral, low laterals. This is going to be left circumflex coronary artery. It comes around this way. And then you have the inferior leads, 2, 3, AVF, will lead you to the right coronary artery that comes down this way. So kind of visual representation that matches what we were talking about earlier. So you might have to reference that video real quick before you jump into this one, just in case you did it later or previously beforehand. As I alluded to previously about the AVR lead being important still, not the most important one, but we still have to know what it looks like instead of just ignoring it like what's taught a lot of the times. So we're looking at the lead of the right arm. It looks like the upper right side of the heart, reciprocal change to the left side of it from the lateral. So this is kind of something you can look at when you're matching the two to make sure it's looking right. All right, so we're going to start with ischemia, and we know ischemia means a lack of oxygen to the flow of the heart itself. So that's when you're going to start having depression changes. As you can see, the ST depression is going on here with inverted flip T wave with inverted T wave going on here. So what happens is the repolarization is not normal when it comes back. So that was what changes the look here, and that negative to positive it changes to going from positive to negative. So you get that inverted inflection going on here. I just want you to remember that onsets within, the ischemia. As soon as that happens is when you'll see it. So you can have somebody who has a heart history from before, and when they get short of breath, they'll start appearing with this quicker than previously because of previous damage. So we move to injury portions of it with the ST elevation. As you can see it clearly going up right here, pretty large, and that there little fireman hat going on there. Happens for minutes to hours. The zone of injury that's happening is where it causes that ST elevation to go up. There's still room for recovery for this portion of it, so time to act is now. So moving on to infarct, we have dead tissue that we're going on here. When you get the pathological Q wave that shows up, as you can see here and right there, it's so significant, but it's a pathological Q wave that occurs there. That damage is done, means the tissue is dead. It cannot be functioning anymore, so it has to take a different path to get there in order to function normally. This can happen between several hours to several days. All right, so looking at some changes for ischemia, injury, and infarct, we're looking at the ST elevation that occurs and the progression of the process of a STEMI from 2 different diagrams here. So as we look over here and kind of where everything starts to you have the inverted T wave that starts off first, starts to kind of pull everything down a little bit, and then the ST elevation with the injury starts to occur, as you can see right there, coming up, everything's still inverted, up, inverted, and you see right there, the start of the pathological Q wave starts to get bigger and bigger to the point where it actually flips the inverse of there. And you can see that here, as well as the same kind of setup here, except for on this one you get like a hyper acute T wave going on here, and then the ST elevation gets pulled up with it. As you can see, it starts to come down. Here's the negative deflection down here as well. Start of the pathological Q, and then the ST segment comes back down, and you see that the permanent pathological Q wave occurs. So just think about it as a progression when the next time you think about where you are when you see the STEMI happening. So STEMI criteria is going to start. ST segment elevation is going to measure from the J point up to 1 millimeter or more. That's one criteria you have to have there. The ST segment elevation has to be present in 2 anatomically continuous leads. So 2, 3 AVF. So it could be 2 in AVF, 2, and 3. Either or, it doesn't matter, 1 AVL, as long as there's 2 of them, then that's another criteria that's met. The next thing is going to be reciprocal change to what's going on there. So you have to have the ST depression present as well with inverted T waves, and that will meet their STEMI criteria. So first STEMI we're going to start with is an inferior wall MI, leads 2, 3 AVF is going to be what's located at the ST cell segment elevation is going to occur. Signs and symptoms can be from any of these things here. Nausea vomiting is more common with most of the things that occur. You can look at all the heart blocks that can show up from it, as well as bradycardia. So sometimes you can have a STEMI with bradycardia, and you don't want to be increasing the heart rate of that because you're going to progress the STEMI a little faster than that. That's not one of the ones you kind of leave there and then manage if it became completely unstable. You need to take care of it. Let's look at this inferior wall MI EKG here. So we're looking for ST elevation and lead 2. Right here, as you can see, more than 1 millimeter box going up, 3, and AVF, right? You have all the first portion of the criteria met. Now, look for ST depression, right? We got it in lateral changes and 1 AVL. We have it right here and lead V2, V3 going on here. So across the board, we met STEMI criteria here, right? We may not have inverted T waves, but we have ST segment depression going on right here as a reciprocal change to the ST elevation going on here. So there's your inferior wall MI EKG. Inferior wall MI with the right ventricular infarction. So a little bit of criteria for this. If you do not follow this criteria and you have a suspicion that ST elevation and leads 2, 3 in AVF, and you have inferior wall MI happening with reciprocal changes in ST depression, you can look at the V4R anyway, and just to cover yourself. But here's some criteria that kind of helps you, suggest you to look at that already. So if you have ST elevation leads V1, and then if your ST elevation in lead 3 is greater than lead 2, it kind of gives you indicative to kind of turn that over to the other side. So all you got to do is similarly put the V4 in that same spot, midclavicular, where it's like on the left side, you just move it over to the right side, and then when you print out the 12 lead EKG, make sure you circle V4R or V4 itself and put an R next to it, so that way they know that this EKG was put in for the right side involvement. Now when you look at it, what you're looking for is ST elevation in that V4R. If you have that, then it's positive for a right ventricular infarction. So let's start with the inferior wall MI first. We have our criteria of ST elevation in 2, 3 AVF, ST depression in 1 AVL, so we got that present and accounted for. And what's the ST elevation here, here, and there? We're not here, but just there, right? So we got that all present. Everything's criteria is met. Now we're looking at the other things. V1, right? We got ST elevation happening there. Lead 3 is greater than lead 2. So boom, all the criteria is good. V4 gets moved over. We print out another EKG. Here's what we see. ST elevation. All right, we got it matched in there. So now we know for a fact this right ventricular infarction is occurring and there's vomit there. So at this point, you don't want to do nitroglycerin. You don't want to open up blood vessels anymore, because this is not going to be an issue with giving more flow to areas. It's going to be a fluid and a tank issue. So make sure you start fluids and get that going. Anterior wall myocardial infarction. We're looking at ST elevation leads V2, V3, V4. Worst prognosis because it's a large area of the left ventricle is affected, and we talked about earlier when I was doing earlier slides about LAD being affected. This is what's the common known as the widowmaker. So signs and symptoms for there: left bundle branch block, right bundle branch block, left anterior hemi block, second degree type 2, third degree heart block as well. So as we look at this anterior wall MI, we're looking for ST elevation right here. So you can see the septal wall involvement here. But every time you have an anterior portion of a MI, most of the times accompanied by the septal, because they're both facing both anterior side of it. So that way you're going to see changes in one and the other most of the time. So we're looking at V3 and V4 for your anterior leads, right? V3 has the ST elevation. The V4 is kind of starting, but not really meeting criteria just yet. But you can see it, V1 and V2 and septal wall involvement here. Here's your inverted T waves going on here, which eventually will pull this down to ST depression. You see it right here as well, 2, 3 AVF. Nothing happening here. It's more of a little more flat, probably eventually pulling down from there as it progresses on there and not treated. Anterior septal wall MI is known as the widowmaker, just like the previous one I talked about the anterior wall. They're all facing the same blood vessel and looking at the same blood vessel, just what part are they looking at the blood vessel. So it rarely presents in isolation. Previous slide I told you 2 slides ago, I said it doesn't present by itself most of the time because they're both facing the same side. And then you have the same signs and symptoms as the previous wall. Anterior septal wall MI, the widowmaker. Now let's look. ST elevation V1. This is septal lead. Another septal lead V2. Nice big ST elevation. I guess not nice for the patient, but V3 ST elevation. V4 ST elevation present. And you can look, starting to have like concave going on here, and you can see it's starting to bring itself down to ST depression or the reciprocal change. So that's your positive indication is anterior septal wall MI. Posterior wall MI. So you're looking at the ST depression in septal and anterior leads, so V1, V2, V3, not necessarily V4, but if you see those together and they're having ACS symptoms, you're going to want to try to get your posterior, the rest of the posterior leads on there. So what you want to do is you take V4, V5, and V6, and you want to take them and you move them to the backside. So so I'm going to show anatomically what that looks like here. So V6 should be sitting over here, right? So when you look at here, you're going to look at mid-scapular. Once you get to that point there, go down, fifth intercostal space, right there, boom. You slap V5 there, right? You move V5 over, right here. That is going to make it when you'll have V8, or sorry, yeah, V8's there. So once you have that on board and you have your V6 here, all you need to do is mark yourself right here between them two, right about there. And then that's kind of similar when you do V4 and V6. And you do your 12 leads, you do 1, 2, V4, V6, and then you throw in the V3 and V5 on there. Kind of same concept. You'd put that in there in the same fifth intercostal space, but you just move V6. Put your finger there, then pick V6 off of there and slap her on there. So boom, good to go. Now when you come over here, so you get your V8, or sorry, V6. V4s go in there, sorry. V6 is going to be taken from here, and you're going to pop it off of there. You're going to mark it with your finger. So you're going to go to the spine in the same fifth intercostal space, right? And the spine, you're going to pop it slightly over to the left, right? And then you'll fit the V6 lead there. So now your V4 becomes V7, V5 becomes V8, and V6 becomes V9. And make sure when you do print out that EKG, you go ahead and write V8, V7, V8, V9 over them. Cross them out. Make sure there's no confusion on it and circle them. So there's none of that. So as we look at the posterior wall MI, like I talked about earlier, V1 ST depression, V2 ST depression, V3 ST depression. You even have it on V4 and this one too. You get these little cutoff up there. So when you do that, you'll say, okay, now they have ACS symptoms. We're thinking they're acute coronary syndrome symptoms. Then now we're thinking, okay, posterior wall MI. Let's go ahead and move the leads over. And when you move those leads over, like I said, you're going to cross that out, V7 circle, cross that out, V8 circle, cross that out, V9 circle. And once you have that on there, you should be looking for ST elevation. If you have that on there, it is positive for posterior wall MI. So lateral wall MI is the next one. We're looking at ST elevations in lead 1 and AVL and V5 and V6. So ST elevation in lead 1 and AVL is going to be your high lateral leads, and your low lateral leads is going to be V5 and V6. And they can occur with other ones, so inferior lateral, anterior lateral, and anterior septal lateral could be there as well. It all with lateral extension, so it's something you want to be cognitive of. So we look here and we see ST elevation is going to be in lead 1 and AVL, your high lateral leads. Boom, that's positive, 2 continuous leads. Moving on, V5 right there, and V6, so it's all present, right? Criteria is met there. Now we move over to ST depression. Inferior leads, boom, ST depression is present. Boom, criteria is met, and here's your lateral wall MI. So now we're going to talk about NSTEMIs, non-ST elevation myocardial infarction. We're looking for ST depression as well. Inverted T waves can be present. No progression of the R wave like we talked about with pathological Q waves. It's a partial blockage of the coronary artery, so that's why you don't get the whole death of the tissue and eventually getting the Q wave formation. When you see these changes on there, you're going to have the following tests that need to be run, and this is something that happens outside of us and EMS, but it's something I wanted to piece together for you to think when you're thinking about all this as one piece. So talking about CKMBs or troponin levels, particularly INT, are specifically related to cardiac muscle tissue. So when they find that those are positive in there, that's when they see that you have an NSTEMI that's present. So with CKMBs, they're released into the bloodstream when the heart, muscles, or the brain are damaged. So it raises really early and decreases early. So it used to be the standard of cardiac tissue testing, like when it comes to doing this particular thing as MIs or NSTEMIs, but it's no longer the standard because of those reasons of the heart and brain, and as well as the muscles get injured. You can get false positives. So when we move over to troponins, we have a situation where you have troponin I and troponin T, like I said earlier, about cardiac specific in origin. The protein is released when the heart muscle is damaged solely, so that this occurs. Another thing to take note is that when it does get damaged in general, it could even be from a cardiac contusion, so just something to be aware of. The troponins usually elevate within as early as 2 to 3 hours after the myocardial injury occurs. Troponin I remains elevated to about 7 to 10 days after injury, and troponin T can remain elevated for up to 14 days. Typically 2 to 3 sets of troponin are required when they indicate a myocardial infarction. The absence of ST segments, obviously something that I stated inside the NSTEMI portion of it, but the damage of the tissue is not full thickness damage, like think like a full thickness burn. So you still have areas where still electricity can flow through appropriately and do the job where it needs to do. So think of it like when you have the ability to, you know how we have cardiac muscle tissue that's damaged or permanently damaged to the point where electricity can't flow through there, then it changes the path of it. This does not do that because it's not significant enough of damage to be able to create that issue. So as we look at the EKG here, we see that the inverted T waves present here in V1, in V2, V3, V4, as well as AVL. And that would indicate the need to get cardiac labs drawn normally when they come to there to signify it being an NSTEMI. So here's the image I was talking about just a little bit, a couple of slides earlier. So I want you to think of STEMI as your stroke and your NSTEMI it being your TIA. So when you see the normal blood flow going across right here, you see that NSTEMI and the TIA formation, TIA kind of level thing is where you have the blockage kind of coming up here, and you still have some flow that can get through, right? So you have the TIA presentation where the symptoms show up and then they can go away within 24 hours. Think of the same thing with the NSTEMI, right? Symptoms shows up, things occur, but you don't see the ST elevation going on because there's not enough. They still have flow that can keep the tissue alive. And as with the STEMI, you see the complete blockage, right? It's complete or almost complete blockage where blood flow is not allowed to go through, or it's a blockage just enough along with vasoconstriction causing the complete blockage, dropping this down level so that it completely blocks it. And that's when you get the ST elevation and eventually the flow to the death of the tissue as time goes on and precipitates that. Now we move over to the STEMI mimics. We got left bundle branch block, left ventricular hypertrophy. Ventricular rhythms can present in that manner as well. Benign earlier repolarization, and pericarditis. The first STEMI mimic we're talking about is the left bundle branch block. We know that the conduction is going to be delayed in the left bundle branch, so it's going to be taking a different route getting there. They're showing different morphology on the EKG itself. The EKG will show a widening QRS greater than 0.2, which is greater than the normal size. You know, the normal size is less than 2.12. And we're going to have a monomorphic broad presentation of R wave in lead 1 and V6, so they'll match the look of each other with no Q waves present. And then a broad monomorphic S wave in V1 that may have a small R wave present as well. And it'll look like a little narrowing kind of thing. And then causes left bundle branch block with CAD, hypertension, and myocardiomyopathy and myocarditis. As in the previous slide, we talked about the broadened QRS complex here and here. You can see the R wave coming up on here, or broadened R wave with that broadened slurred S wave going on here. You can see going on there. And they'll match each other in V1 and V6. On this side, you kind of see that R wave we were talking about earlier. Narrow R wave going on there in that V1 section, dropping down the S going on right here. And then the another presentation of the V6 and V1, you'll have that notching kind of bunny ear presentation that can happen there as well. So as we look at the left bundle branch block 12 lead EKG, we see our broad and R waves going in lead 1 and V6, and the amplitude are different, as you can see, between the two, but they're matching the same similar look to it. Inverted T wave going on here, as you can see there, the widening QRS complex, right, and there as well, so that criteria is met. And we look at V1, we see the little notch R wave sitting right there, and then you see the deep S wave going on here. So now you know the criteria is met and you have a left bundle branch block. But if you look at it, you can kind of see why it could be misunderstood for a STEMI, right? Because you have that look right here. Even though the S wave's kind of deep and slurred, you kind of see that segment over here kind of being a little bit raised up there. And if you kind of look at it, you kind of looks like you got ST depression going on here. You can kind of look like it is that in that sense, but just keep an eye on what you're looking at and what you're seeing so you know what you got there. So, although it's not a STEMI mimic, I wanted to introduce right bundle branch block here too, just because in conjunction with the left bundle branch block. And then we say we have a conduction delay, and same thing, just in the right bundle branch than the left bundle branch, and the same issues you think about when having the 0.12 greater than 0.12 widening of the QRS complex. And then you have depolarization, is occurring slightly in a different time frame than the left side. So when it goes across, you can see over here in the images, and then the left ventricular side is going in the normal pathway, and then the right one that's having the branch block is causing it to be slightly delayed because they can't travel the same path to get there. So now when it's allowed to get around to travel, it's over here. So they're slightly off from there, but you can see the R is higher than the S. So the R wave is higher on the right ventricular side versus the left ventricular side in the R wave. And then it creates the RSR prime. That's the prime symbol there when you do see it there. This is what it looks like in the timing when it is together. But this picture right here just shows you the difference of both of them separately when you look at it in more detail. So just think about it, greater QRS complex, 0.12 greater than the normal number, is just less than 0.12. And have the slurred S wave in lead 1 and V6. Now you did have a slurred S wave leading in previously in V1 and the left bundle branch block, but now it's the opposite, right? You're looking for that slurred S wave sitting in lead 1 and V6 this time. You have the RSR prime, what I was talking about earlier, here. And the causes of right bundle branch block could be myocardial infarction, pulmonary embolism, pulmonary hypertension, myocarditis, and congenital heart effects. All right, so when we look at lead 1 and V6, we're looking for that slurred S wave, right? And right here, these are different formations you might see of that S wave, but all of them match the slurred portion of it. The way I like to think of it is like you could fit a carrot in there, right? Because you got your rabbit ears, you fit a carrot in there. And all these different shapes of the carrot, right? So slurred S wave going on in V6 and lead 1, they mirror each other, right? That's matched the criteria. And now we go over to V1, and now we're looking for that rabbit ears, the bunny ears that you hear when you're doing EKGs and you're learning EKGs for that right bundle branch block. It's in V1. When you see that in there and they're together, that is a complete bundle branch block, a right bundle branch block. Now, if you do, as in previous, you have the criteria for the left bundle branch block, but you're not meeting it completely, or you're not meeting this completely, with either or is missing. Like if you have this, but you don't have these, it is incomplete right bundle branch block, or incomplete left if you're meeting some part of that criteria, but not all of it, for further reference. Now when you look at the right bundle branch block 12 lead EKG, we're going to looking at lead 1 and V6 here. We're looking for that slurred S wave, as you can see. Slurred S wave going on here as well, so that criteria portion is met. It's more promptly in this one than it is in this one, but that criteria is still met. The amplitude inside V6 is less than lead 1. Now we move over to V1. We got our bunny ears going on here, as you can see. They're RSR prime, and the taller one is their prime. And as you see, that's met as well. So you got the bunny ears and your slurred S waves. Your right bundle branch block has met criteria. So now we're next to the next STEMI mimic, the left ventricular hypertrophy. We're going to look at criteria here. You're going to be adding the width of the S wave. You choose either V1 or V2, whichever one's the deepest. and then you're going to look at the height of the R wave, whichever is the tallest, at the V5 and V6. And when you add those two, counting the small boxes, you should have more equal to or greater than 35 millimeters. And if you do, then it's considered left ventricular hypertrophy. When you look at the other halves, or the other portions of criteria, the R wave and the AVL is going to be greater than or equal to 11 millimeters. R wave in lead 1 is going to be greater than or equal to 12 millimeters, and then the R wave in lead AVF is greater than or equal to 20 millimeters. Now, you don't necessarily have to have every single thing to have it be and meet the criteria of left ventricular hypertrophy, but if you have one of the sections, it will be meeting criteria for it. As we look at the left ventricular hypertrophy EKG here, you see in lead V1 or V2, take the deep S wave, whichever one's longer. It is in V2, which is 25 millimeters. And in V5 and V6, we are taking the measurement of V5 because this is longer than V6, 13.5, which gives a total of 38.5, which is higher than 35, confirming the left ventricular hypertrophy. Now, the other criteria have been R wave and AVL is greater than or equal to 11. So as we look at AVL, that is not the case. R wave in lead 1 greater than or equal to 12. Lead 1, nope, it's not the case. And R wave in lead AVF is greater than or equal to 20. And you can see it's not the case there. You got about 10 going on in there. So you don't need all these things to match to get the criteria. You just need one of those to match to get your criteria. Now we look at another 12 lead here, and we're going to go with criteria V1 or V2. V2 has a longer S wave. Let me get one. 23 here. V5, V6, which one's longer? So it looks like they're roughly around the same height. So we'll choose V5 here. And it looks like we got about 19 there, so we are way over criteria on that. So we have met the criteria for left ventricular hypertrophy. Now let's look at the R wave on AVL and see if we're meeting 10 above 11 or equal to. And that is not met. Let's look at lead 1 and see if we're meeting above or equal to 12. Nope, we're just underneath it by 10. And then the R wave and AVF, this is equal to 20 or above, and it is not. Next STEMI mimic is benign early repolarization. For the criteria for that, we're going to be looking at a concave ST segment elevation, widespread but often not seen in pericardial leads, as in V1 through V6. A notching or slurring of the J point looks like a fish hook kind of appearance when you look at it. ST segment elevation is usually less than 2 millimeters in the pericardial leads if they are present, unless it's 0.5 in the limb leads, which is the 2-3 AVF, 1 AVL kind of thing. No reciprocal changes are present with this, and no progression or change of ST segment morphology over time. So that's a way to understand that this is not a STEMI. So we're going to look at this example of benign early repolarization here. Looking at this concave ST segment elevation we're talking about, right? Using these criteria, isoelectric lines here, 1 and about 2, so about 1.5, 0.4 if you're splitting hairs here. But you got that fish hook appearance we're talking about, right? And it's widespread and can be seen in this right here, pericardial leads, right? Boom. The notching, you got a little bit of a notch right here. You can kind of see a lot better here, and just it's not really that bad there. The notching is occurring on there for the ST segment elevation, and we are in the pericardial leads, so we're looking at less than 2. So you can see this one's just about above that. If you count it right about here, it's right on that line on the cusp, and this one is not underneath. As we look at this benign early repolarization in 12 lead here, I know the grainy portion of the image is not well. I couldn't find a really good clear one for some reason over the internet. But as we see here, you can see that concave going on there with the notch going on there, and the ST segment elevation happening, right? Lead 2, 3, AVF going on, and that's where I was trying to show the progression there. But you see across all of this, there's no ST depression, this entire EKG. You can also see it right here with the little notch going on. This is starting to come up on there too with some acute T waves here. All right, next on the STEMI mimic list is pericarditis. You know the pericarditis is the inflammation of the pericardium. It's usually caused from a viral infection, but it can be bacterial. ST segment elevation is diffused to across the entire thing because the entire pericardium is affected by it. So it's going to be on every lead you will see, and then AVR will just be upside down, as you can see. You got the PR depression going on with it. Diffuse ST segment elevation, swooping upward, concave ST segments, kind of similar to that fishhook appearance, but not exactly the same because the notching is not there, so you don't get that look to it. But notchings can be at the end of the QRS complex. So as we look for pericarditis in this EKG here, you can see the ST elevation I was talking about with the concave portion going on there, as well as here. It's not as much as this here, but you can see it going on there, and it's not in the same sense of the notch you would see with benign early repolarization. So you can see it right there, and across the board you got ST elevation kind of coming across, nothing going on in these leads. And the biggest thing, I'd like to say across all the board here is that when you look at pericarditis, you're not seeing ST depression occurring. So that's something I want you to keep cognitive of when you're trying to break whether or not it is something whether it's not a STEMI. All right, so this other EKG here for the pericarditis, you can see the ST elevation 2, 3, and AVF kind of starting up there, not almost complete meeting criteria, but you can see the concaveness going on there, like was talked about on the criteria. And you can also see it coming out on this side too. You can see a little bit of a notch here and notch there. So you got some benign early repolarization going on in these leads right here. So this is 100% not going to be a STEMI. No ST depression going on. So something to be cognitive of when you're looking at these. Axis and its deviation, the rule of thumbs. So to figure out axis here, we're going to go to this simple setup here where you would take your left hand and it'll be lead 1 and you will hold it above your head. And if you get a QRS complex that's facing like this, you would put the thumbs up because it's facing more up than it is down. And if you get one QRS complex is like this, then you're going to go ahead and put thumbs down because it's mostly facing down. And then your lead 1, like I said earlier, is going to be higher up because I want it to be like what you see it on an EKG. And your AVF is going to be lower down. So the left hand, put that one higher up. The right hand, put it lower down. And face those to match the EKG, the QRS complexes of those leads. So here we have an example of normal axis. And you can see in lead 1, that if you use the rule of thumbs, it's going to be facing up. The QRS complex is facing more up. AVL, more of it's facing up. So IVF, sorry, most of it's facing up. So now both thumbs are up. Left axis deviation. What causes it? Left bundle branch, inferior wall MI, with Parkinson-White syndrome, left ventricular hypertrophy, left anterior fascicular block. So as we follow our criteria here, we're going to go to lead 1. In lead 1, QRS complex is facing up more. So you put a thumbs up on there, down to AVF, and the QRS complex is facing down more than it is up. So now you have a thumbs up and a thumbs down. And as you look at both of those together, remember I said lead 1's higher and AVF slower to match the EKG, right? What are the thumbs doing? If you follow the direction the thumbs are facing, they've left each other, just like the picture shows right here, right? They have left each other. Now, this highlighted part, lead 2, when you had left axis deviation, or you're meeting criteria with the lead 1 and lead AVF, you use lead 2 to confirm if it really is completely left axis deviation, or it's starting to do it and it's not fully to the part where the degrees are pointing in that direction. So you look at lead 2, and if lead 2 is still facing up or more QRS complex similar to lead 1, then it's not left axis deviation. But if it is like it is right here, where it's facing down, it is correct and it's confirming that it is left axis deviation. Right axis deviation, causes for that will be a lateral myocardial infarction, COPD, PE, right ventricular hypertrophy, Wolff Parkinson-White syndrome, left posterior fascicular block, and dextrocardia. So right axis deviation, we look at this EKG here. You're looking at lead 1, or the S wave here on the QRS complex is facing more downward, and the QRS complex on AVF is facing more upward. And then there, as you take your thumbs and you face them each other, this one being 1 and this one being AVF, like I said, above and below. And there, if you go in the direction the thumbs are facing each other, they're going right at each other, which gives it right axis deviation. Extreme axis deviation, the causes for that are ventricular rhythms, hyperkalemia, severe right ventricular hypertrophy, and emphysema, and artificial cardiac pacing. So when we look at this EKG here, lead 1 has the complex going more south, right? And EVF has the complex going more south as well. So as they're both facing down, like this picture here suggests, it's no bueno. There's your VTAC. So in this EKG, we're going to look at the signs for pulmonary embolism. It's called the S1Q3T3 pattern. We do know that as at the time of this recording, it occurs in 30% of patients that have pulmonary embolisms. The other 70%, this EKG finding does not happen there. So as in the name suggests, S1Q3T3, S1 is going to look at lead 1 for that one. You're looking for that S wave that goes down and slurred just like that. So you can see it is present. The next one will be Q3. So you're going to go to lead 3 and the Q wave. Q wave is present. Yes, sir. And then, and last but finally least, T3. So you lead 3 and you're looking for inverted T waves. Boom. There they are. Good to go. So this has met that criteria, the S1Q3T3 pattern that happens in 30% of patients with pulmonary embolism. Now, a lot of people have confusions with heart blocks, and at this point I'd like to put this to end off the EKG presentation here to help people differentiate the difference between the two. So we're going to start with Mobitz 2, second degree heart block type 2. The regularity for it will be regularly irregular. The rate, it depends on the underlying rhythm. The P wave is going to be uniform in shape, one P wave in front of everyone, round, upright, all that kind of good stuff in the criteria. PRI is going to be 0.12 to 0.20 in seconds, and QRS complex is going to be less than 0.12. So one thing I wanted you to understand when you look at this is the PR interval, right? It is the same every time you see the full beat is present, correct? Every time you have a drop beat, right? It's not present. So when you think about when you're looking at this, I want you to look at the PRIs and see those when you're trying to differentiate this between a third degree heart block. Now when you're looking at this, understand that sometimes the morphology of the QRS complex might not be the same. It might be wider. It might not wider. It might be in the opposite direction, facing downward, like the previous axis when you have one facing downward, the QRS complex with deeper like S wave kind of going on. And it might make it look slightly different. It might make it a little confusing. But just remember, as long as the QRS complex is less than 0.12, it's not ventricular in nature. It doesn't take over and change what it looks like, right? And the PRI has to be in that small window. The window that it's in, and if it meets that criteria, it's good to go. But the PRI is the same every time you have a beat. It's the same every time. So just take that away from this slide. So this image is provides here shows the QRS complexes that are occurring right here in your T wave and your P wave, and your PR interval is the monkey, the PR monkey. And you see he's here, he's present, catches the beat doesn't drop. But over here, oh, Sparky could not catch that fast enough, right? And now the beat drops and you just got a P wave by itself. Then you came back over here and you got the PR monkey, the PR interval still present, and you still keep going on forth from there. So same thing, like I said, PR is the same when it shows up and the beat has dropped. So don't confuse that when you do see a third degree heart block. But this can just know that it can progress to a complete heart block as well. So the third degree heart block, we're going to be looking at regularity of being regular. Atrial rhythms, the atrial portion of it is going to be from 60 to 100 beats per minute. Ventricular rate would be 40 to 60. The P waves would be uniform in shape, but there'll be always more P waves than there are QRS complexes. PRI will have no relationship between P waves and QRS complexes because P waves may be present or may not be present in the same vicinity of it, or may be superimposed onto the QRS complex itself. QRS itself can be less than 12.12 seconds if it's like a junctional focus, but if it can be wider than 0.12 if it's a ventricular focus, which is why I said earlier when the QRS complex looks a little bit different. With these in particular, it can come from both that junctional with the small QRS complex or the bigger one, right? So you can have a one that looks a lot bigger and more closer to like an idioventricular kind of look of QRS complex. So don't be tricked by those. Follow your rules, right? So when I said the atrial rate of 60 to 100, we're looking at right here. If you count this P wave to this next one here and that one here, And you go across just like that. I'm just going to point them all out, all the P waves from where they are. You're going to get, if you do your math there, you get from 60 to 100, you get in that range, right? QRS complex, from there, all the R to R's, right? They're all regular, right? Just think of it that way. They're just not talking to each other. There's a problem there, right? They even notice the block is complete and doesn't allow any sinus impulse to get to the ventricles, so they can't communicate. So the ventricles are like, oh crap, I need to start conducting because nobody else is doing their job. Otherwise, we're going to die. Turns out they're just not knowing somebody else is doing their job up there. So the atrial conduction will be normal, then regular to itself and unaffected. And then the block will be being complete. The ventriculars, will do that overconduction to try to solve that problem themselves, even though the problem is not either of them. So the slower rate with it is because it's from that focus of where it's coming from. So that's why the rate is slower. So if you think about this to try to break apart from second degree type 2, Mobitz 2, or third degree heart block, you just come down here because both of them have more P waves than QRS complexes, right? But then look at the PRIs, right? You go back to PRIs. Is there one here? Is this the same as this one? Nope. This is not even present because of how far away it is, right? And you have one right here. You can argue that, right? And you can argue this one. And you can argue that one, but it's never the same coming across. So here's a graphic where I show the highlighted atrial rates and the highlighted ventricular rates. You can see from that same EKG finding you saw there in the previous slide. Look at it right across, marching across of all the P waves. And you come over here and look at the QRS complexes. They're regular, like I said. They're still in their normal rates from the focuses of where they're coming from, but they're not talking and they're not lined up together. And that is why this is deadly, because you're not going to get the fluid from the atria to the ventricles in that time frame that you're supposed to. You might have one squeeze, you might squeeze at the same time, you might not squeeze at appropriate time frames. You might squeeze way too early before the ventricle finally squeezes again, and then it'll squeeze, and then there goes the P wave again. So that imbalance and irregularity can cause death. Here's a fun image to show to understand that more. And you can see that the QRS complexes are here in the blue, right? And here's the P waves in the back in the red, and they're not talking to each other. It says so on their phone. Look at their cell phone. They're not talking to each other. Death has taken the track off of it, because you can die from this, like I've stated earlier in the earlier slide. So it's a nice little image to kind of help you memorize them. They're both independent. They're operating on their own time frames, as if they have different life in a different body. So that completes my presentation, and I'd like to leave off with some quotes here. The moment will reveal how much you've trained, and those you know, and been in those moments, you don't have to speak about them to other people unless you want to be better. But you know what that means, and you know how strong and powerful that quote is. To obtain maximum attention is hard to beat a good mistake. And if you look into my office, there's that image where the books, and I always say green books. There's a reason for that. And then the last one is my quote I like to say the most. It is no one's fault but your own if you choose to stay stagnant. So always improve, always try to be better. Don't just become stagnant and less a provider. Not one who doesn't know anything and starts to lose everything that they know. They don't try to stay relevant. They don't try to sharpen their skills. They just coast. Don't be that person. If you have any questions, feel free to contact me and I'll do my best to help answer them for you or provide you the information you need to get the answer you seek. Here's a last thing I'm going to leave you off with the next 3 slides. It's going to be a STEMI patient I had while I was at Lima Fire. I was working with Grant Schroeder, and we had this patient that, as you can see here with the ST elevation present, in V2, V3, V4, and V5. And this patient itself was experiencing ACS symptoms, and they were given 1 nitro. So this happened at 14:59, and that nitro was given. The next EKG was at 15:05. Still 1 nitro was given only, and 324 milligrams of baby aspirin as well. But look at the ST elevation that dropped, and look at the significant change. Look at that. And the last one was 15:07. 1 nitro only, aspirin 324 milligrams, no ST elevation present at all from where they were. Isn't that amazing? Pretty neat.